of hydroxy in sickle cell disease. So I'll just give a little bit of a background before we get into the meat of it. And I want to believe that everyone has I want to believe that everyone has already at their sides the standard of care guidelines, both the hard and then the soft copy of the standard of care guideline. Jacob, I cannot turn this. What is how do I advance this? Who's next? Where is next? No, I like to use the log. Yes, please. Okay. Okay, so we have in sickle cell disease, we have evidence-based interventions that we know to have worked in the lives of people with sickle cell disease that have actually helped to increase the life expectancy of sickle cell disease. This disease that was discovered over 100 years ago actually, started getting attention in the US when they had the law they're called the National Sickle Cell Act, whereby they started screening for sickle cell disease, and then the use of oral penicillin with blood transfusion, hydroxyurea utilization that really, as you can see, from 1970, remarkably raised the lifestyle extended the lifestyle of patients with sickle cell disease. So although this has happened in the US, in most of sub-Saharan Africa, mortality.
We have units to do meeting now. Happy.
Please, can you mute your devices? Can you please mute your devices? Please mute your devices. Okay. So in sub-Saharan Africa, the life expectancy is still like the mortality for sickle cell disease is over 75% in under fives. So the context of our talk this morning, the work we are doing is in the context of the NIH-funded major infrastructure grants in sickle cell disease. That is the Sickle Pan-African Research Consortium, which is in 6 African countries with the Clinical Coordinating Center and a dating center in South Africa. And then you have in Ghana, in Mali, set up a registry for patients with sickle cell disease. In Nigeria, we have the SPACnet, the Sickle Pan-African Research Consortium Network, where we have the registry in 25 clinical centers. And these are the site PIs across the length and breadth of this country that are participating in this study. And so we have, we are carrying out this work. Jacob, I need to go back. Yeah, okay, it's touch screen. It's not moving. So we are carrying out this study with the standard common case report forms, which we are using in the enrollment of the patients, and then we are also following up the patients prospectively with the use of uniform case report form follow-up forms. And then about halfway through, we started this study in 2017. About halfway through the first SPACO 1, we decided to analyze the patients in the registry. And so we found okay, so we found that this is the phenotype of patients that we found in the registry when the registry was 4,700. And then we found out that the rate of blood transfusion was very high. And we found that penicillin prophylaxis utilization was low, pneumococcal vaccine was low, and we were surprised to see that hydroxyurea utilization was just 13.9%. And it wasn't, it wasn't surprising that majority of the patients, because they were not using this disease modifying treatment, were actually receiving blood transfusion. As much as 59% of the patients were on blood transfusion. When we looked at this registry this year, we found that the rate of blood transfusion had indeed increased, but the hydroxyurea utilization is still hovering around 13%. And this is actually why we decided that we were going to kind of talk to ourselves, in order to do something about this. When we found out about the low utilization of hydroxyurea, we were worried, and we did several studies, as you can see the references below, where we tried to look at what the barriers to hydroxyurea utilization was. And then we found that these barriers were at the patient and parent level, at healthcare provider level, and at health system level. Most of the time, the cost was an issue. People felt that hydroxyurea was expensive, but in reality, this is not really so, because when you say somebody that go and get, when you say that people should get hydroxyurea, they take that and they go, not knowing that there is actually a hydroxyurea that is made in Nigeria. So that is hydroxyurea. So they are not quite aware about this, and they go for the expensive imported brands. But the brand of hydroxyurea that is made in Nigeria is made by Bond Chemical Industries. It's quite available and is affordable. So, and then one of the barriers also was how to procure the drugs and the lab monitoring. Although we have had studies in Nigeria, in Kano, in Ibadan, in Jos, that really, especially Ibadan and Jos and Kano, that show that the low 10 milligram per kilogram body weight of hydroxyurea, can actually, impact, is efficacious and is safe to use. So then the other barrier was the perceived side effects and the safety profile in pregnancy, and then parents' perception of the disease severity. So because once you tell them, they go online and they read, and then they say no, they don't think that their child, needs to be exposed to this. And then of course, the fact that you cannot use it in pregnant or lactating women. Then on the side of healthcare providers, we have limited knowledge of the drug. And this is why we are having this meeting today, this webinar today. We've had several webinars. As a matter of fact, under the office knowledge, of physicians and providers on hydroxyurea, and then so that we can feel confident to educate others, and then we can feel confident in prescribing. So another thing was the lack of confidence to prescribe the drugs, and then doubts about its efficacy. So today, I'm really going to look at some that actually show that this this drug can be used with confidence in Nigeria and in sub-Saharan Africa. And then, of course, another thing is the ignorance of availability of the clinical data on hydroxyurea treatment in African populations. Today, we have a wealth of evidence, which we can point to, which we can look at, to increase our confidence in the use of this drug. Then at the health system level, I know that back then we had actually, I think the first, the guideline for in the management of COD, our national guideline set very strict criteria for the use of hydroxyurea. But this guideline has been revised, and it is, it's making it easier for people to enroll patients, and prescribe hydroxyurea for their patients, so that our patients can have access to this disease modifying treatment. And then one of the other things is the lack of pediatric formulation in circulation. So now, Bond Pharmaceuticals, I'm not their spokesperson, but I'm a Nigerian. They are saying that they want to make a pediatric formulation. But it's also good to know that the preparation of 100 milligram, 200 milligram, and then those lower formulate the tablets, so that the patients mothers can actually use it to dose their babies appropriately. And then another thing, a barrier, was a poor transition from pediatrics to adult care. Why am I saying this? Is because hydroxyurea utilization is actually more in pediatricians than in adult hematologists. So when you look at, I want to be seen. So when you're looking at, except if you think that showing my face will, yes. So when you look at that's 13%, the 10% is actually being given by pediatricians, and only 3% by adult hematologists. So adult hematologists have to do something about their reluctance in using hydroxyurea. So when we looked at the data, from studies across Nigeria, we found that there are areas of improvement in the use of treatment. What we are responsible to give the patients the safety and about the efficacy of hydroxyurea, because when you tell them and they go online, they can't find anything. They are not able to analyze the study, evaluate the studies, and they may not even see something that is current or in proper context. So this is our responsibility, and that is why we're having this talk. Then also health provider training. People need to be trained on the use of hydroxyurea. But more importantly, we have to use hydroxyurea within clinical guidelines. And so that is why today we are going to look at the guideline for the treatment of sickle cell disease using hydroxyurea. And then another thing is education on clinical studies regarding the safety. So we are going to discuss a lot of these things today. And then we do advocacy. If you look at in September, there was an opinion piece which some of us wrote in the Lancet Hematology, and it was a call to the Global Fund to please add hydroxyurea to the Global Fund, so that they can the Global Fund, using that mechanism of how they have provided a treatment for HIV and AIDS and TB, that they can add hydroxyurea, so that our patients in sickle cell disease in low middle income countries can have hydroxyurea using the same logistic and supply chain mechanism. And then another thing that we need to improve is to advise ourselves about the real cost of hydroxyurea. Please in Nigeria, if you want to prescribe hydroxyurea, prescribe oxyurea. And when they look for oxyurea, they find that it's not as expensive as the hydroxyurea that they will find in pharmacy shops. And then another thing that we need to improve on is the clarity regarding side effects. So this is very key. When people know exactly what the side effects are and the, and the relative safety of the drug, they will want to actually use oxyurea. So this is oxyurea by Bond Pharmaceuticals. I'm not marketing this product as a salesperson. I'm just highlighting it as a physician working in Nigeria that we want my patients to have access, and then we also want to advise other physicians and healthcare workers about the use of this drug. The presence of this drug is a proven effective remedy that is used worldwide in sickle cell disease. As a matter of fact, when the studies, the NIH-funded studies in northern Nigeria that were designed to see how we can, if we can use hydroxyurea for the prevention of stroke, primary stroke prevention and secondary stroke prevention. The investigator, the US investigator that led that study, took from the open market in Nigeria, took this oxyurea, took it to America, and then analyzed it, and he found that it was as good as the foreign, just from the formulation, 100 milligram, 250 milligram, 500 milligram. So doctors should prescribe oxyurea, not hydroxyurea. And patients should ask for oxyurea, not hydroxyurea. So Bond Pharmaceutical Industries has the capacity to make oxyurea for the whole of Africa, but currently operating below capacity because physicians are not prescribing this disease-modifying drug. So we need to do something about that. Having said that, I just want to quickly take us through a number of studies. I'm just going to show it this way, just for you to know that from 1984, there's been so many studies in so many countries about different aspects of hydroxyurea. First, they were doing it in adults, and then they wanted to know whether babies, even young children can use it, and then even babies. And all of them, the clinical experience with hydroxyurea for patients with sickle cell disease has been accumulated for more than 25 years, involving adults, children, and adolescents, and even infants. And several multi-center randomized studies are still going on. So I'm going to refer to some slides or some content from an ASH publication where Dr. Russell Ware, who has extensively used hydroxyurea both in the US and across many African countries in clinical trials, where he's saying how he uses hydroxyurea to treat young children. And I believe that because Professor Ware is a pediatrician, so pediatricians obviously are ahead of the game. In the use of way hydroxyurea is a single inexpensive, and increases the level of hemoglobin. It is cell count and reticulocyte, lowers the age. Out of the LD, so this point of care test is Gazelle, the Gazelle. So it breaks into fractions, and you can tell. We use it in my lab to monitor, the response to hydroxyurea. Then we also the hemoglobin is what everybody can do, and then it reduces the white. We can easily do white cell counts in our labs. Then also the clinical efficacy. This drug ameliorates anemia. You can see that the level back in the slide where I showed you that 59% of our patients are receiving blood transfusion. Just tell me how much does it cost a patient to go through the processing to receive blood transfusion versus how much it will cost that person to use hydroxyurea and avoid blood transfusion. Most of our patients will tell you that since I started using hydroxyurea, I've not been going for regular blood transfusion. In fact, I've not been. That is the testimony. Consistently using hydroxyurea because it raises the HB, and then it also leads to fewer VOCs. In fact, I have one of my patients, she started on 2012. She's never had a VOC since she started. Neither has she been hospitalized. And it also decreases the hemolysis. So the treatment goes, if we work in all, this is a drug that works in all age groups from babies, to infants, to toddlers, to young children, on and on. Even those ones, adults who already have started having some chronic organ dysfunction, have shown improvement in their whether it's in the kidney function, they've shown some improvements in their organ function since they started. So the benefits continue over time. And then it's not like an antibiotic that you become resistant to it, or it in fact is unbelievable. People do not have tolerance to it. They continue to get better as they use the drug. And then the monitoring, I think 17 years on in one of the studies, they've been monitoring the toxicities, and they have found that relatively it has a wide therapeutic index. So they are properly monitored. There are no major short-term toxicities, and then no long-term sequelae or complications of therapy. In this, in our center, Professor Gomadu published, a case of a young child that accidentally overdosed by very, very, very wide margin. And then she continued to monitor the child, and there were really no serious adverse events from that. So how does it work? It works by fetal hemoglobin induction. This fetal hemoglobin, it quickly wanes, from 6 months, from birth, and completely wanes at 6 months. That is why a fetal hemoglobin that is protective wanes. Then the level of HbS is increased, and then the patient start getting symptoms. Then, so if the fetal hemoglobin rises again, then it's inhibitory. It inhibits the cycling process, and so through the soluble guanyl cyclase activation and alter the erythroid kinetics. So it really helps the patient to do better. Then it lowers the neutrophil and retic count. If we look into the pathophysiology of sickle cell disease, we find that it's not just the sickle cells that are the problem. there are also tissue molecules that recruit neutrophils and then reticulocytes. They form together, to form the particles that cause cellular. And then it also has anti-arrhythmia all together. Also through improved erythrocyte hydration, you have microcytosis, reduced intracellular sickling, and more importantly, it increases the nitric oxide, because it's in the pathophysiology of sickling, reduction of nitric oxide, through the heme, mopping up of heme, haptoglobin and heme, causes vasospasm, which also, hydroxyurea increases nitric oxide, and it helps to improve the vascular response. So one thing that if you read, if you read a guideline or you read hear about people saying maximum tolerated, and then that tolerance at 50 kilogram body weight, and you have an eye feels reticulocytes, and then you don't want to go beyond 35 milligram per kilogram body weight. So you are looking at toxicity, but the normal dose, so at that level, when you go beyond 25 milligram per kilogram body weight a day, you're able to achieve thresholds of hemoglobin above 9 grams per deciliter, and then you're also able to achieve MCV greater than 100 femtoliters, and then the fetal hemoglobin, we're able to get it, approximately 20. Some people it may be more. Then if it's a standard, at least you get fetal hemoglobin increase of up to 15%, which still, helps some people. So published reports document sustained lab and clinical benefits for some patients with sickle cell anemia who receive. If you notice, I've been saying sickle cell anemia, not sickle cell disease, because it's not really been demonstrated well, if at all, in sickle hemoglobin SC disease. So those patients with hemoglobin SS who receive long-term hydroxyurea treatment, it has shown to improve, that it prolongs survival and improves their quality of life. So the guideline that we are going to refer to shortly is going to tell us what kind of monitoring that we need to do with HUT at maximum tolerated dose. So this is again a slide I borrowed from blood from Professor Ware. So you can see at the A to C panel, A to C shows the patient's blood before they started treatment, and then how the blood was coming back to normal shape. You understand, the normal biconcave dish shape, as they are increasing the doses up to maximum tolerated dose. And then even when it was a standard dose, there was still that good response in terms of the way the peripheral blood smear looked. So whether you're giving maximum tolerated dose, which people are really scared of doing, although there's really no need to be scared, or you're using the standard dose, there is some improvements in restoration of the looks. Even at 10 milligram per kilogram body weight, which is low dose, that you still get some good effects. And the study by Professor Najiba Galadanchi and the team in Kano show that even at that 10 milligram per kilogram body weight, there is still some positive response today. So assuming we are so scared that we don't want to go for the 20 milligram or the maximum tolerated dose, we can still use the 10 milligram and just let our patients have the benefits of this disease modifying treatment. Next slide, please. Okay, so now, we have to be true to ourselves. So how did we find out about the side effects? The side effects are from the clinical trial have been done. And so when they are doing this double randomized placebo controlled clinical trial, they don't know who is getting what, but they are looking at the labs, at the results, and they are looking at the patients, and they are documenting complaints from the patients. And they found that usually the side effects are mild with most children. I'm talking about children now. Mostly no effect on growth or development in children. Occasionally, patients may describe headache or mild GI symptoms, including abdominal discomfort or nausea. Some patients may develop them as they come. They say, my hand is now dark. They say, yes, it's because of the hydroxyurea. But the hand is dark. It's not itching them. It's not paining them. It's just dark. So, and then, of course, the nails may also be dark, and this might make them feel a little bit uncomfortable. But if you think of what the drug is doing inside of you, that's a small price to pay. And these side effects are sporadic and they're not dose dependent. Then some skin ulcers have been reported, but the skin ulcers have happened the prior treatment arm equally as in the non-treatment arm. So we don't know. Then hepatic and renal dysfunction from hydroxyurea treatment has not been reported, although this is something that we want to really check and baseline and monitor, throughout the time that the person intermittently. Then fertility effects. This is the one that gets the Nigerians, because once you say hydroxyurea, they go online. Once they see fertility, sperm count, they say, doctor, you don't like me. In fact, one patient of mine came and was very angry with me. And I said, what's the problem? He said, you gave me this drug. I said, yes, you have to live first before you think about that. And then studies have shown that these are very reversible. So HU used during conception and pregnancy, there's increased odds ratio. So in fact, it's not advised that you use it in pregnancy. But some patients in the US and who have used hydroxyurea, and then they just use it through their, they didn't know that they were pregnant. And then, and some even that they used to, the severity of their disease, but no one has had any adverse events on such exposures on the fetus or the mother. Okay, then what are the benefits? The hydroxyurea is associated with reduced risk of developing sickle cell disease related complications. It has reduced transfusions and infections. It gives lower rates of hospitalization, and it improves survival and health-related quality of life. So the reason that you see the survival curve in a patient with hydroxyurea in developed countries is because they are not at 13%. Everyone there is using hydroxyurea. So that is why you're getting better benefits in them. So our own Professor Najiba Galadanchi and Julie Cantor, no, it's not July, I'm sorry, Julie Cantor, who she works with in Alabama, they had a commentary recently. The commentary is based on the long term, right? Because the REACH study was launched and they are carrying on with it. It was in 2014 and they are extending it is a study in Saharan Africa between the found when children were given drugs in Nigeria, 635 children and November 7 months started hydroxyurea at a dose of 15 milligram per kilogram body weight per day for 6 months. Then they escalated the dose up to maximum tolerated dose. Then they escalated it until there was mild bone marrow suppression. And this you judge by the absolute neutrophil count. You don't let it fall below 2. Then the results of this trial demonstrated that at maximum tolerated dose, hydroxyurea can be safely administered to children in sub-Saharan Africa, giving clinical benefits, including decreases in rate of VOC episodes, acute chest syndrome, recurrent strokes, serious side effects, excuse me, serious without a serious adverse effect, without the risk of, because people were afraid, will we have malaria? What will be the effect on malaria? So they showed that it is safe even in sub-Saharan Africa. And then they were even saying that, oh, maybe there's even a small improvement in terms of people having less episodes of malaria. So this trial provides strong evidence for the use and management of hydroxyurea in sickle cell anemia, and children in this environment can benefit even from the maximum tolerated dose, and that it is safe and well tolerated, and it only had mild hematologic toxicities. Unfortunately, this was done in East Africa, but we are going to carry out our own study to see how we can increase the adoption of hydroxyurea in our own environment. But our study is going to be an implementation science study, because when physicians don't do what they should, then you try to see if other people can help them to do it. Go on, next one. Okay, so now when they say guideline, so it means that group of experts got together, they looked at the literature very well, and then from the literature, from studies, from their own experience as experts, they set aside, there are clear rules on how to develop guidelines. So the Sickle Pan-African Research Consortium, that's consortium that I told you that is in 6 African countries, in the first 4 years of its work, developed a standard of care guideline, multi-level standard of care guideline, one for the teaching hospitals or last referral hospital, for district hospitals, for primary health care centers, and for home care. These guidelines are available. But I know that when we developed the Nigerian guideline, it was mostly in the shelves. It was more on the shelf. Please, can you mute? Please mute yourself. So it was, there was a Nigerian guideline. So it wasn't useful to our patients. You understand? It wasn't useful to the healthcare worker. So the first thing that you do when you have a guideline is available. Why? It's so that not treating their own service and them become working at standard guide. I'm going to go through this guide. When we train ourselves and when we are implementing, what else can so that when this guide them. So it's very important. So I'm going through it. See that the pages are more, that you have more pages because it's smaller. But we produce this one and we did it bigger, so that it won't get lost easily. So the pages that I'm going to talk on are pages 23 to 33 in the, this one that is for us here in Nigeria. This has the names of all the healthcare, the SparkNet PIs. It has the names of our SparkNet PIs and their addresses of the hospitals where we are doing this that from the SparkNet network. So, and I'm going to go through patient eligibility criteria. That is what can you show my face? Show my face. Yeah. So, yeah. Okay. So this is our own guideline. This is our own standard of care guideline. You can see this is a map of Nigeria. These are the centers, in our own guideline. And then this has the contact number of all the institutions where we are using this guideline, to work. And then it also has the phone numbers of all the phone numbers. So you can call those institutions and you can set up an appointment to see patients, to go there and see the patient. So this is our own guideline, and that's what we are going to use. So we are going to try to adhere to this guideline in the management of our patients. So let's go. So now I'm going to cover patient eligibility. This is what I will cover as in the guideline. Next slide, please. Okay. So I am aware that it is just maybe not taking what it's doing. Please. So who is eligible in terms of, so you can see the eligibility, and then it tells us chronic nutrition therapy. No points now going. Then chronic utilization of medications that may have toxicity is not advised. Go on. Okay. So of course, we have to evaluate the patient, take the history, So the lab test, you can. Okay, the lab test that you do, we don't want this to interfere because of the low bandwidth. You can close. So the lab test is the FBC, then your BUN, your LDH. You know, we have to tell ourselves, most of us cannot do LDH except if we are in a funded clinical trial. But the liver function test and the renal function test, the bilirubin and alkaline phosphatase, we should do. You understand? Comprehensive metabolic profile. But the FBC, we should note the absolute retic count, then the absolute, because this to monitor, do HB quantitation. I know it's expensive, but we want to see if they can bring Gazelle to our site so that we can use to close the video and close it. Thank you. Then we want to keep track of the HbF. Then if we can, serum ferritin, the person that made the vendor for Gazelle said that he can do now, I think maybe by November, it will be able to do serum ferritin. So then how do we monitor? We have interim visits, and then which is at 12-week intervals, which coincide, you know, most of the time we tell the patients to come in 3 months or 4 months. And then we also have when we are starting the dosing, we ask them to come every 4 weeks so that we do the blood count. Then, so this is telling us exactly what to do, you know, how to monitor by the lab with the labs on. Then toxicity. So there is toxicity. It can be hematologic or non-hematologic, and then, you know, adverse events. So the toxicity is when the absolute neutrophil count starts decreasing below. You remember we said this from 2,000. So if it starts going below 1,000, there's retic count, absolute retic is going below 80 per microliter. Then the platelets count. And then if the HB is falling, then you know that there's bone marrow toxicity and you stop. And renal dysfunction. So you're looking at the serum creatinine, and then you're also looking at hepatic dysfunction. So you monitor all of this. Then if there is adverse event, an adverse event is defined as any unwanted reaction, side effects, other clinical events in which continued continued therapy might contribute to drug toxicity. So as defined. So what is the dose? Excuse me. So it's a children, you start with 20 milligram per kilogram once daily, and adults you start at 15. Then if patients have chronic kidney disease, you know, you use a lower dose. All of it is once daily. Then you escalate the dose as defined here. Go on. So if there is hematologic toxicity, then you have to monitor closely. You have to withhold the dose until recovery, and then the blood counts, you check them weekly until recovery is complete. And then you now start, but at a lower dose. Go on. Okay. So this is talking about what to do when there is then the bone marrow. So it's important for us to know that parvovirus. So before you conclude that the fall in HB or fall in retic is due to hydroxyurea, you have to make sure that it's not parvovirus infection, which has a similar mechanism. I mean, it gives a similar lab effect. Then also this is telling us about dose modification if it's non-hematologic toxicity and adverse events, and then what to do. So there will not be any restrictions on blood transfusion for patients on hydroxyurea therapy. Assuming you're just starting and the patient has a stroke, of course, you have to apply the standard treatment for the management of acute stroke, and then you continue with the hydroxyurea. So what else? So then transfusion during, so you don't restrict transfusion. You don't say, oh, this person is on HU, so if they are severely anemic, you will not give them a blood transfusion. You have to just follow. And then if you are starting patients on hydroxyurea, you have to advise them to take contraceptive or to practice strict abstinence, and then you send them for birth control. And then it means miss periods, and then you do pregnancy and is on hydroxy, and management. So there are several brands of HU that are available. That is why I say in Nigeria, our own hydroxyurea is oxyurea. Why? Even in our own environment, even when you ship it abroad, it has remained stable. So what to do about pediatric formulations? Our pharmacists can compound for 2 weeks and then you go back and take. But I think they are also trying to formulate the oxyurea, while Novartis has already the pediatric formulations. But so it's important that you get the right. I don't think they are faking it yet. So it's good for you to get the right brand that is affordable for you to use. So then how do you manage the treatment? So although HU for sickle cell disease is not a research study, the implementation of treatment, so this is exactly as is written on the guidelines. So the implementation of HU therapy for people should be as carefully monitored as would a long-term research studies. Doctors and nurses are not familiar, but it's not toxic. It's quite safe. So we should not be afraid of it. We should continue to start using it, continue to use it, tell our patients about it, be in a position to advise our patients so that they're not afraid. And then if they bring something from the internet, also show them. So we have this guideline for patients, you understand? And then we have several materials for patients that can help them, and we disseminate. So our doctors, our nurses, our pharmacists should all work together, so that we're able to give hydroxyurea to our patients. Next slide, please. So we are going to have at this SparkNet site, some SparkNet sites that have shown high enrollment in the registry and have shown continuous follow-up. Yeah, they have a high rate of follow-up. They are going to go into a study where we want to step down the use of hydroxyurea to lower levels of care under the watch of these eminent hematologists and pediatricians. So it's an implementation science study that we want to manage sickle cell disease through increased adoption of hydroxyurea in Nigeria. This is a study funded by the NHLBI in conjunction with and NYU, and shows where the studies are going to commence, with possibility for expansion into other sparkle sites in future. So next slide, please. So what have I tried to say? That the level of hydroxyurea utilization among our patient populations had remained low at 13% over the past 4 years, despite increasing evidence from studies done in Nigeria and other African countries about the efficacy and safety in our environment. Oxyurea is affordable and locally made. We have gone through the standard of guidelines for its use in referral hospitals, but this drug can also be safely used at lower levels of healthcare. So I said that Dr. Issa is going to talk about it, but actually I think I've kind of covered this. And this is what our implementation science research will be, so that we can see how hydroxyurea can be scaled up for the benefits in our healthcare centers, for the benefit of our patients with sickle cell disease. So on behalf of my team at CESTA, I want to thank you for listening, and we will take your questions.
Thank you very much. Let's appreciate Professor Nuggets. Thank you so much. And, we know today is Friday, so we're conscious of that fact, but we'll quickly have some discussions. But before we start, just to remind us that please, the link for the posters has been posted. While we're having these interactive sessions. So please, floor is open for questions. Help us identify your song to speak and then ask your post or your question.
Hello, can you hear me? Can you hear me?
Yes.
Okay, so please, this is
Yes.
Professor Koch. I noted when you talked about, thank you very much for your very in-depth lecture in this area. It's very much welcome. I noted when you talked about ulcerations, and in your write-up, you noted that in both arms of something there were ulcers. I didn't quite get what you were saying at that point. So I want to know whether hydroxyurea will be beneficial for patients who have ankle ulcers or no.
This is a question from a professor of hematology. Professor Kocha, we have to, so for me, I would say, I know that when we started, when we wanted to start using hydroxyurea, I read a lot about it. And one of the cases that I saw that was like back in the 70s, study that was done that showed that is what this that it have the you can't really There are lots of studies that I
Hello. Sorry. My apologies to everyone. We lost internet connection. We're back on now. Please, Dr. Issa. Dr. Issa, can you hear me? If you can, please, can you address the questions being raised? Hello. Hello. Hello, can you hear me?
Yes, we can hear you.
Okay, so please, Dr. Issa, Prof asked that you should address the questions.
Okay,
or any other person who is there. Please, we have a lot of specialists here.
Sorry,
Any of the questions, please, people can address
because of the network fluctuation, I didn't get the question.
Okay, the question had to do with Lagosas and please, Professor Kocha, can you repeat the question?
Okay, if it is that question, I had it. I thought it was a different question. So actually,
okay, no.
Hello, can you hear me?
Yes, we can.
Okay.
We can hear you.
Actually, for leg ulcers, some people have experienced breakdown of leg ulcer, especially those who had it before commencement of hydroxyurea. And in the criteria of inclusion criteria or eligibility criteria, actually there is a place for case-by-case basis, you know, depending on the individual. If a patient is having a breakdown of his leg ulcer, you know, I think it will be best to withhold the hydroxyurea and monitor the patient again. And then there are toxicities. We've seen the management of the toxicities. When you withhold hydroxyurea, you watch out for recovery of that toxicity and you can recommence again the hydroxyurea again. So maybe that way we can, you know, make a better judgment. But there's also a place for case by case, you know, judgment when we want to implement it. I don't know whether that is helpful. Over.
So
Thank-
can anyone else try and answer this question?
Hello,
Because
ma. Hello.
yes, we are all experts. Yes. Yes, go
Okay,
on.
please. I have an experience with that leg ulcer with two of my male patients. When I started them with hydroxyurea, the wound actually broke down again. And when we stopped, the wound started healing. And because of that, they didn't want to continue with the hydroxyurea again, even after
Okay.
counseling them. But
Okay.
I observe it clearly.
Okay. Okay, that's great. So who else? Any observations, any experience on the use of hydroxyurea for patients with leg ulcer? So I guess this is a potential area that we need to check very well, mind the literature well. That study didn't come out clearly against, you understand? So I want to maybe suggest that somebody should do a systematic review, right, on it. Yeah, and see. So we look at the literature critically to see, you know, what the experience has been, especially in areas where you tend to have more. And then we can ask our Indian colleagues as well, where they also have. But I doubt if the Indian haplotype is not the same as ours. But we can find out. Okay. So the thing is that since we are not using, since when our rate of utilization is low, we may not really be able to say much until we use a bit more. Okay. Lawsuits. Do you have experience with your patients might not be at that leg ulcer stage? If you're speaking, IJ, can you unmute so that you can speak?
I wasn't speaking yet. I was listening to the question.
Okay. Okay.
Hello.
Good
Yeah.
afternoon, ma.
Yes, I know that Akinyemi will speak. Please go ahead. Yes, you have the floor.
All right, ma'am. Thank you very much, ma'am. Yeah. Regarding the issue of leg ulcer, well, maybe I will speak from the pediatrics point of view. So we've actually, with what the last doctor actually mentioned, we've not observed that as in the association of the hydroxyurea with leg ulcer, as in worsening leg ulcer. So we've not been able to we've not recorded that, although we don't have so many patients with leg ulcer. That's number one. So, but even some of them too that are using hydroxyurea, not that we've been able to associate that with deterioration in their condition. So then again, I actually check a literature now talking about the evidence-based management of sickle cell disease, the expert panel report of the 2014, where the most of these guidelines were documented, even on hydroxyurea.
Mm-hmm.
So what they wrote there, under the evidence profile of side effects of sickle cell anemia, so they put leg ulcers that the available evidence does not support the association of hydroxyurea treatment with leg ulcers. So meaning that is actually, at least for now, as you said, ma, so maybe more research will need to be done on that. But the current evidence doesn't actually completely suggest that. And if we talk about leg ulcer too, we know that it also, even spontaneously, it breaks down, it heals, and so on and so forth. So I think it would be good to look into it. But the current evidence in the literature is actually saying that there's no association. Thank you, ma.
Thank you. So this is why what I like about our network. We are all experts, and anybody could have done this, and I'm sure that this is just to start us so that we can do the same, you know, at our site. What we do, we don't prepare slides, we just go on the guideline itself, and then we just go through the guideline page by page each time there's a new person coming to our site. Over. So in the interest of our brethren who are going to the mosque, I hope that these 24 persons I'm seeing is representing, like in this room, how many are we? Is representing we're 13 persons in this room. And I hope that, so if you can please, what we do, because what we do is when we have talks like this, in the room, we have more people than one. So that we get a good idea of the number of people that are listening, because 24 is not a lot.
Please, can you put on your...
My video is going, my video, 4, 5, 6, somebody stepped out. My registrar, senior registrar, and the research assistants are all here.
Okay, can we take, can they come? Please put on your video. So document.
My video is on.
Okay.
There are a lot of other people, so yeah, please go ahead.
Yes,
Yeah.
yes.
Your videos.
Please
Now,
come. All of you should come to your videos so that we can take a screenshot.
There are a
Oh,
lot
I
of
see.
people who have not put on their videos. Please put on
Where
your
is Dr. Lawan?
take a screenshot.
Hold on.
Please, Nnamdi, put on your video. Nnamdi, let's see you, please.
Dr. Digan, I saw your policy maker. She told me that I think he's Dr. Ronke Akonde. So she said that she's interested in screening and that she's budgeting for it. So
wow.
that was a
I
good
just told her she's budget for it, so that's good of her. She's keeping her word then. Thank you,
Please,
man.
everybody.
Dr. Maduka, Dr. Ifenu, please, can you put on your videos?
Rukayat, where you did?
Okay.
Can you see us?
Yes.
I don't know if we can see. I hope your faces are showing.
Okay. So
Can you see
hydroxyurea.
us?
Yes.
Okay. So you have a screenshot of all sides showing how much you want. It's funded, so
All right. Yes. Well done. Okay. Any questions, comments?
Are you taking my picture?
Yes.
Okay.
Your picture on the
You're
loan.
looking very nice.
Thank you, ma. You too.
My residents will be interested in how to escalate the dose. One of my residents.
Yes, I think that is what we are. Those escalation. It's there now in the guideline.
Yes, I thought so. Yes. I've given copies out, but the people who had it are holding on to it. I've told them to bring it back and let others know. So, other than
We
that,
sent some more. 5. Okay. I think we sent some more in that parcel that you got.
Really?
Yes. Yes. We sent some more copies.
This girl, hey. Yes, the research assistant is saying that she saw some more. She didn't tell me.
Yeah, I can imagine.
I will cure her
We
quietly.
sent some more.
Don't worry.
Yeah.
So quiet.
Okay. All right. So we want to thank everyone. And any more comments? Do you want to say anything? Go on, let them see your face.
Is it Dr. Issa?
No. This
Or
is
Mr. Tayo?
Mr.
Hello, sir.
Hello,
Good afternoon.
Good afternoon. He's very tall, so it's difficult to fit into
Yes,
the
I
camera.
Good to see you, sir.
Good afternoon. Some of those.
Good afternoon.
Good afternoon, sir.
See some of
This network.
and looking forward to our implementation of the Accelerate. I think all of us have our forms now, so we expect that from next week we should start getting some responses from the sites. And
Okay.
Prof. Nobi, there was a question about when do we think we will start the HU therapy on Accelerate? I think February, right?
Yeah,
January, February will be the Accelerate.
Yeah.
So thank you and looking forward to a good project.
Okay.
This is-
Sorry. Hello, Mr. Tayo.
Yes.
This is Kelechi on Accelerate medical project medical officer.
Hello, Prof. Man.
Charity on Accelerate and pharmacy. Yes. Yes. I can for us. Ofakuri.
All right.
We
ma.
can hear you now. Over.
Okay. Thank you, ma. Mr. Tayo, we actually spoke with Mr. Tayo a few days ago. So regarding the issue of the full blood counts that we were asked to do, as in for the recruitment of the patient. So what I actually what I thought and what I discussed with him was that if we should do the full blood count now, and we're now starting the hydroxyurea in January, so would the full blood count still serve as a very good baseline data?
No,
So I was
No,
thinking
it
that
we're
that we
not
should
yes.
so that we should wait till when we want to start before we do the baseline full blood counts.
Yes, yes. Although you've been giving the money now, it's not
Yes.
now. Not for
Yes.
now. It's for when we want to start.
Where?
All right, man.
Yes.
Oh, they wait. They come. Okay. Then they
Yes.
just-
Yes.
Okay,
Okay.
thank you.
Yeah, thank you very much for that. So I want to thank everyone for participating, and please let's continue the interaction on the chat group. And when you're coming back, you bring something for us. Okay, so we send the slides to you, and
Hello?
then if
Thank
you
you.
more copies of the guideline that you can use, just let us know. So we wanted
Hello?
to, yeah, we wanted to print the
I need to
protocol,
show.
right? So we want to print the protocol and we missed the opportunity to send it. Yeah, it was a waste the day. We will add copies still. We want to mark. Thank you very much. We want to greet our brothers going for prayers, and we want to thank everyone for attending. Thank you very much.
Yeah, of course.
Thank you, ma. Bye-bye, everybody.
Yeah, bye-bye. Thank you,
Thank
man.
you, everyone.
Thank you, sir.
Thank you,
Mas.
ma.
Bye.
Thank you, Baba.
Next time. Bye. Bye.
Bye-bye.